an extra minute, but it's 6. Former military guy. It's really hard to go late on it. I'm sorry. We're going to just get it going. Well, welcome. I'd like to welcome everybody on the call. And, I think this is an important call. And I think there's a lot of things that we're doing right now with the Western Vascular Surgery Society that are important. And I think the Vascular Surgery Interest Group is a very important part of that, because that's our future. And, we're very fortunate to have this committee created. And so today, I'm Niten Singh. I'm at the University of Washington. On the call, we have our chair of the Vascular Surgery Interest Group, Dr. Misty Humphries from the University of California, Davis. And we've got Dr. Leigh Ann O Banion from UCSF Fresno. Then we have our guest speaker, Dr. Michael Amendola, who I'll introduce in a second. But we're going to get started with just a little bit of discussion on Vascular Surgery Interest Groups. And today, we want to talk about tips and tricks on creating one. What can you do to be successful? How do you start one? In general, and then how do you maintain it? And in the group, I'll start with us at the University of Washington. We started one about, I think it's been about 6 years, 7 years. We've had a vascular surgery interest group, and I've talked to Michael Amendola about this, and we've had fits and starts with it, and I think we've had some that have been very successful, and then some where it's a little more difficult. And I think with COVID, we've had a little bit of difficulty, but it's opened up opportunities for us too with some of the virtual options that we've seen. And we have our interest group and the medical students come through and they work on research projects with us. They shadow, and I think that it's something that I think every place that has a medical school should be trying to do. And so I think we can be better about it, just like everyone else. And so let's hear from the panelists. Dr. Humphries.
Well, it's very exciting. Whenever we started the Western Vascular Surgery Interest Group Committee, the goal was really to see how we can help programs as well as to engage students and bring more students into our field. I think we have a very exciting field. I think everybody here would agree with that, from the open to the endo cases that we do and the long-term care. Right now, we are just about getting ready to end our scholarship run. So the scholarships have gone out for the Western Vascular Surgery Interest Group Committee. All of the people that are on the panel, if you haven't gotten information about that, Heather can send it to you if you put your email in the chat. But we have a scholarship this year for students to come and attend the Western Vascular Surgery meeting. And that scholarship is $1,500. We're giving out 10 of those. And we've put together a program for the Western Vascular meeting where we are going to have breakout sessions for both students and residents to get them engaged and also to give them information about why we have such a great field and help with that. The other thing that's really neat about the Western Vascular Society is that it's something that I remember going to years ago to ask Mike Conte for a job as he comes on now. And it's where you got to meet program directors. It's where you got to meet division chiefs. And it's where you really kind of built a regional home as you were going through the years. Niten, having seen some of your residents at meetings too, Jake, who was a student that rotated with us years ago, now I see him at the meeting. I think it's a really good opportunity. So in terms of local vascular surgery interest groups, we did a survey of our membership and found that about 50% of our member institutions don't necessarily have a vascular surgery interest group. And I think we all want to have one. We want to be able to reach out to students. We want to integrate with students and help them see how wonderful our field is. But I think it's hard. And I think right now with COVID, we have a lot of competing priorities with different things. And so finding ways to do it and do it well and also keep it sustainable is really important, which is why I'm very excited to have this discussion tonight and have the availability for program directors, associate program directors, and those that are interested in education here so that they can learn. So thank you, and I'll turn it over to you. Technically, you're about to be the chair of the interest group committee, so you don't have to call me the chair anymore.
Oh, you're still the chair. You'll always be the chair. And so, Dr. O'Banion, you're at UCSF Fresno, and you said you get medical students. What has been their experience with vascular surgery interest groups or their knowledge of vascular surgery as they come in to rotate with you and you work with them?
Hi, everybody. Good evening. Well, Misty was kind of hard to follow. She put everything so well, but I think we have the main campus UCSF medical students come down and rotate with us. And they, Dr. Conte has had a VSIG for a little while now. And so they do get exposure to vascular, but I think they're really excited and they're eager to learn more. And I think it's really important as our society, we need more vascular surgeons. And so we're not going to get there unless we breed that interest early on. And the only way to do it is to get it started. And so we actually don't have one. So I'm really looking forward to this talk tonight to see what kind of tips and tricks I can learn to potentially get things going down in Fresno. So I'm pumped to hear what he has to say.
Great, thanks, Dr. Banion. And Dr. Conte is on the call as well, our president of the Western Vascular Society, and we're very excited to have you on this call, Mike. And what at UCSF, you guys have a vascular surgery interest group, and what are you guys doing with it? And do you think it's been successful, or has it been impactful on getting people to go into vascular surgery or surgery in general?
Yeah, thanks, Niten, and thanks, Misty, for your leadership in this area. We're really excited to make the Western Vascular more visible and more available to interested medical students and get them engaged around what we do. And we started our VSIG during the pandemic, and it was super helpful because it just gave everybody a way to communicate, or just before the pandemic. And one of the things we did kind of right before we got shut down was coordinate some opportunities for hands-on simulation type activities. We had one, really big one, which drew a lot of interested folks before, unfortunately, the virus made us stop doing in-person activities. But communicating about our grand rounds, our speakers, and also opportunities for shared education like that has been really valuable. Also, I think it's enabled us to reach into the class and have people self-identify. That normally we sort of think that people will come up and approach us, but it turns out I think that that's not the easiest thing to do, and maybe even more so right now with COVID. So it sort of established a home where interested students could feel things out a little bit, and so I think it's been a good thing for us to establish. And I think going forward, we're looking forward to getting back together in person with our VSIG. We haven't had a chance to get all those folks together in one room, in a long time, but hopefully soon.
Thanks, Dr. Conte. Okay, without further ado, I'm going to introduce Dr. Michael Amendola, our guest tonight. Dr. Amendola did all of his training and went to medical school at VCU and did his surgical and vascular fellowship there as well. And he has been, on top of that, he went and got a master's in medical education at Hopkins, and is chief of the Division of Vascular Surgery at the VA in Richmond, as well as the Senior Innovation Fellow. And he gave us a talk last month at the University of Washington about his work with innovation and the 3D printing that they're doing for VA wise. He's in charge of that and thinking about like the printing they're doing for mass and for orthopedic surgery, for vascular surgery, and very, very exciting research projects that he's working on. But the reason you're here, Mike, is because you all seem to show up at the vascular annual meeting with about 15 medical students, and they have 15 posters that they're presenting. And that's where I met Dr. Amendola. I think it was about 6-7 years ago at the VAM, and we're walking around and we're look at all these posters from VCU, and you had just great topics, and the students seemed really engaged, and I think you've done a wonderful job with it. And you've spoken to us at our institution about VSIGs and how to have a successful VSIG. And without further ado, I'm going to ask you to go ahead and tell us your tips and tricks. And thanks for being here.
And thank you, as always, for the kind words and for the invitation. Really enjoyed speaking with you guys when I was up at PNEC at that meeting. Misty, also meeting with you was fantastic. You guys argued again about who was in charge of this committee. But let me share my slides and get going, because I don't want to waste anybody's time here. So let me see if this vascular surgeon can figure this out. And I can hit share. And then you guys can see that. We good? Okay. So thanks again. I'm Mike Amendola. I'm from VCU. I'm going to put up the standard. This is the standard VA issued disclosure that they'll put you in jail if you don't put it up, saying that basically I'm not representing the government, but I am representing my views, my observation, and my data. Briefly, what we're going to do tonight is I'm going to talk about what our practice is, what VSIG has been at VCU, the pivots that we did with the pandemic, the top 10 tips to those of you starting VSIGs or thinking about VSIGs, and then conclusions, kind of where I think we're going. And then any questions and interaction with you guys, feel free to stop me in the middle of this. I'm happy to take any questions. So who are we? This is the Richmond VA. So this is a cruise missile view of the VA, that we are 1A facility in Richmond, Virginia. We're the second largest building in the state of Virginia behind the Pentagon. The construction here to the left is an expansion of our spinal cord injury unit. And then on the far right here is where we are building our advanced manufacturing for 3D printing. So it's a very exciting time within our VA. We're roughly a 350 bed hospital. We offer all shapes and forms of surgery, as well as advanced medical care. This is our group. I lead additionally 4 other surgeons. And then Kato Lavingia on the far left just joined me now 2 years ago. What's interesting is that all the gray beards used to train me. So it's an interesting inversion in terms of power, that you're able to hire people to come back. They are all part-time physicians, and currently Kadar and I are the only full-time surgeons at the VA. We are looking to hire. So if anybody would like to spend some time in Richmond, Virginia, please reach out to me. I'm happy to talk to you about our job. This is VCU. So our VCU Medical Center is a level 1A, is a level 1 trauma center in Richmond, Virginia. It's the only one. The next closest neighbor to us is UVA, and then EVMS to the west. We have a general surgery program here, roughly 40 residents. We just went from 5 to 6 residents per year. And we have roughly a complement of 5 residents that are at the VA, 2 of which are assigned to our vascular surgery division. This is just a smorgasbord of what I do in a given day. The top are all of our research residents. So I have 2 research residents in our quality lab, and then I have 2 research residents that are doing 3D printing with us. So Sally Boyd and then Lucas Keller-Beal are both doing 3D printing. Diana Toya and Alex Simmons are both doing CRQS, or Chief Resident Patient Safety and Quality. Down on the left is what I do a lot of now, which is 3D printing. This is a back model that we printed for VCU. And then I'm an adjunct faculty at Hopkins. So I do that on the side as well. So VCU VSIG. This is Grayson Pitcher. He is from close to your guys' neighborhood. So he just finished at Mayo this past year, now joining Michael Stoner at Rochester. He came to the vascular rotation at the VA by accident, was assigned to my service by accident, and decided that that's what he wanted to do. He came to me roughly 6 months later and said, we need to start a VSIG. I said, what is that? And then 1 year later, you can see this is the members of our VSIG 1 year later. So this has been an interesting journey. I find that in times in your career, when you get dragged into things, it's pretty amazing what ends up happening. Even though you think you're not going in that direction, it's been an interesting thing. SVS defines VSIG as promoting vascular-related research and service activities for early exposure, but more importantly, discernment. So helping, I think, junior learners really think about what they want to be when they grow up. This is a crucial thing right now with the USMLE going past fail. I think getting learners very early on to decide that they want to do vascular surgery is going to be crucial. And VSIGs are going to be a crucial part of the armamentarium for us to figure out who wants to be a vascular surgeon, but who can make it through the training and who really wants to put the time, effort, and the resources behind it to be trained appropriately. The structure of our VSIG when we started, we had preclinical medical students, which is a major part of our core. Clinical medical students, i.e. third-year medical students, also a major part of our core. General surgery residents, interfacing with that. Vascular fellows, which are actually stationed at VCU and not at the VA within our practice, are a very minor part. And then the attendings carry on a major part of what we do in our VSIG. We usually start the year off with a talk. This is a kind of an attending talk. What is vascular surgery? We talk about the match statistics. We talk about possible research and VSIG activities, which I'm going to go through shortly with you. This is a graph that I figured out after a couple of years of doing this. So there's pizza interest, strong interest, and leadership. So roughly you have 30 students show up, you provide food, they show up. So that's called food stimulus. You have interest, 12 students will walk up to you. They will say, I will email you, I'd like to do something. Only roughly 8 of those students end up with an email. And of those, usually about 4 end up becoming your VSIG leadership. Of those initial 30 to 50 students, we usually get 12 students that have some interest in vascular. And then here are the numbers again. You have 4 students roughly in your leadership, stronger interest in 8 students, and then core members of 4. It took me a couple of years to figure out that you should let the leadership decide what research they want to do. It's a natural way to get students into leadership positions by giving them a head start and giving them first dibs on potential research projects. And it's a nice way of recruiting people into your leadership. The events through the year: lectures, hands-on lectures, simulation labs, research and outreach from the VSIG. This is one of our lunchtime lectures and learn at the top. And then here at the bottom, this is Jan Acosta, one of our previous graduates. We also did a lot of career panels. So this is a panel on the top right here with 2 interventional radiologists and myself, lower panel here between cardiac surgeons and myself. So this is important, I think, to help students really hear verbally the differences of our specialty. What we know day to day as vascular surgeons, it's very important that they understand. They get to ask questions and they really get to really think about, hey, what is it going to be like if I'm really a vascular surgeon versus CT surgeon versus an interventional radiologist? We do a lot of hands-on. These are 2 pictures here. The bottom one is Matt Weschenoff, one of our general surgery residents currently at VCU. So this is a vascular ultrasound course. And then at the top, this is a suture anastomosis. This is one of our mega hands-on labs that we just did right before the pandemic. Again, and it goes without saying that all pictures here with with students with no mask on clearly is before the pandemic. We did the mega hands-on here. This is Dr. Lavingia. This is right after he started, where we had multiple stations, and then we combined with our general surgery interest group as well to come up with a variety of stations. And I'll go through some examples of that shortly. We actually describe that. This is a paper that I did with James Dittman, who'll be one of our graduating medical students this year. This is the COMET framework, looking at designing an escape room for vascular surgery, in terms of coming up with different contexts. And this shows you here, room 1 was a cerebral vascular room, room 2 aortic room, and room 3 was an acute limb ischemia room. So coming up with identifying pathophysiology, figuring out from a variety of different teams that you could put together, not only between medical students, but nursing and pharmacy, and pulling that together and figuring out. And then the task-based challenge, a lot of these are wire-based skills for the students. Research is a major part of what we did. Niten had mentioned that. This is Meg Reeves above us here at the top here at the previous VAM. And then down below here is Grayson Pitcher, who actually won one of the poster competitions one year. But we push for clinical based, non-clinical based, regional meetings are important, and then national meetings as well. This is a crucial thing, I think, for anyone thinking about VSIG, is figure out what exactly is the schedule of your medical students. I still struggle with this, and I circle here all of our, what I call the sweet spots to do potential research, in particular in their first year between their fall and then their spring semesters, and then the summer break, which actually has a dedicated dean's scholarship, which we've been a part of for the last 5 years, which allows students actually to come to the VA and do a lot of dedicated research. The 3rd year, notice there's no circles. That's the big black box. They go into their clerkships. They're learning about kids, they're learning how to deliver babies, but they're not thinking really about vascular surgery. So you kind of remind them that you're there, but in reality, you let them kind of be and let them get through their clerkships. But the 4th year is the crucial thing, and setting up research projects from 2 into 3 is crucial, because 4th year is crucial to get them in the exposure in terms of what's going on in our specialty. We break down everything into clinical and non-clinical kind of research projects. These are low stakes and non-clinical, national databases, online educational materials, and online program materials. Clinical are high stakes, clinical data, case reports, smaller parts of larger studies, and usually are on site. These are just two examples here. So this is Danny Shu, who just graduated graduated now is at Iowa. He looked at Twitter activity at the national annual meeting versus interventional radiology. And then he also he did a dedicated Dean's scholarship year with us, and then also looked at statins and the protective effect in thrombosis for radiocephalic fistulas within our dialysis patients at the VA. This is a kind of an output. Everything in red here shows you the number of projects. So in 2015, when we started, we had roughly 10 projects going on that year. We had our high point in 2020 with 25 projects, and then we dipped down most recently in 2021. This is the direction where we go. We try to present at the annual vascular meeting, our local Virginia vascular meeting, our meetings within our medical school, our surgical society meetings, the VES, the SCVS, the ACS, and then the Academic Surgical Congress. So just like most academic surgeons right now, it's a pretty busy time to get through all of these abstract deadlines, which are in the next week or so. This shows you the stacked outputs. So the previous graph now with everything stacked on top of this, you can see the SCVS posters in orange. You can see the podium presentations in the lighter gray. The SVS posters that have kind of stayed increased. We had our high point in 2019. I think we had roughly 10 to 12 posters that year. We had roughly, I think, 9 or 10 this past year at the SCVS. So posters seem to be a pretty good output for us in terms of a lot of our VSIG activities and our medical student involvements. But this was a discouraging thing that I found, was that I was getting one student about every 3 years, every other year. So this was part of what was concerning to me, to try to figure out how that I can stay engaged with students. And what I was finding was that a lot of the medical students and the residents were combining their efforts in terms of what we were doing in terms of actual papers that we were writing at the time. Then I got lucky and I hired this guy. So I think it comes to a point where you figure out, all right, what do I need to do to make this work better? And part of it is letting part of it go. And so I was able, and I was lucky enough to recruit Kedar Lavingia from Stanford, who joined us now just 2 years ago, just before the pandemic. And he's been a God save to me, not only in the clinical practice, but the ability for us to extend what we do with our medical students, our residents, and our educational, our research activities. That's turned into this, which is now those students, and you'll see them stacked up after this, but we're now averaging 5 to 6 papers per year with medical students as primary authors. This has been crucial in our ability, and this is becoming, I think, our key to the realm of getting our students involved with research, but also within our specialty. So this has created 2 parallel loops now where you have medical student papers going on, in addition to residents having their own individual papers, which has been pretty crucial to our success. So we all pivoted like you did with COVID-19. Our medical school went through its growing pains. This was a issue for our medical students where they were not actually being vaccinated within VCU Health. This is a pretty big problem. They were removed from the educational environment, which made it pretty difficult for us to engage with them. And I'll show you how we kind of got around that. We also know that there was educational disruption going on within USMLE, the changes within this study, making it pass fail and the discontinuation of the clinical skills exam. And then what was close to home for us was there's an incredible amount of society disruption in Richmond. This is actually a picture of Jeb Stuart statue being removed from Monument Avenue. So Richmond underwent a fair amount of social disruption in the midst of all of this going on as well. So how do you engage these students amid these disruptions? So we started looking at this, and we started our year, instead of doing our physical in-person meeting, we did a launch meeting that was virtual. So this was actually a big Zoom that all of the interest groups did. This is the slide that we put up, which was basically a scan that could lead you to some more information. But this gave you basically the sketch of who we were. Dr. Lavingia noted here, and then Dr. Daniel Newton, who's same level as Dr. Lavingia, but at our academic affiliate, talking about our research, suturing skills, and then lunch, likely Zoom lectures, and then shadowing and leadership opportunities. So this was a crucial way to get our year started. this turned into this other picture here. So it went from pizza interest to what I call couch interest, 20 students that were willing to click, link interest, 10 students signing up for emails and sending us multiple emails, Zoom interest, they wanted to follow up, and then out of the house interest that they actually showed up at the VA potentially to do research with us. So this took us from 10 to 4 students, and it led to this. We got rid of kind of the stronger interest students, and we have kind of the leadership and then core members that are somewhat associated with us. I think it's crucial to say this at this point. It's important to mentor all students. It's important to not coerce students to say, okay, I will do mentorship if you help me with this research. So the way that we handle it is we tell all students, we will mentor you. We're happy to give you advice. If you want to do research with us, great. If you start a research project and drop the ball and still want to get mentored by us, great. So you have to really have those hard conversations right at the very beginning so that everybody's on the same page to kind of disconnect as a research advisor from a mentor. I think that's a pretty crucial thing. And there's actually an emerging literature from Michigan talking about how you potentially could coerce students by getting them involved with research. So the way that we handle that is we just separate them completely. We establish our online identity. So this is our VCU VAS squad, and this is run by our residents. And this creates a really much a team effort. This is the actual birthday cake that our residents gave me about 2-3 weeks ago. This is a nice aorta with I guess a posterior aspect of an aneurysm. And then we also like to promote when we have our trainees go to national meetings, especially our medical students. It's a fantastic way to connect our trainees, our general surgery trainees with our students that have an interest in what we do. We changed our kind of in-person escape rooms to a virtual escape room. So this is an example of a virtual escape room. And this was set up by James Dittman, one of our lead VSIG leaders, looking at how you can answer these questions to get to the next room virtually. So it's an interesting way to think about how we set up a game environment to have students kind of engage with our subject matter. This was a virtual rounds that I set up. This is called a 3-9-27 learning session. So I took 3 students, put them on the hot seat. I told them there would be 9 slides in 27 minutes. So this is an example here where I'm going through claudication and the basis of claudication. And then I question and ask those students several questions. We do 9 slides. That's it. I prepare 9 slides and it's 27 minutes. At 27 minutes, I turn it off. So the students really like this format. It was pretty enjoyable right at the height of the pandemic. It really allowed us to engage with a lot of students. Our project management has changed a lot. This is Diana Toya, one of our general surgery residents, but we have similar meetings with our medical students. So we do frequent meetings. Ideally, I like to have meetings less than 30 minutes, and we fall back to in-person for issues and for encouragement if there's issues that arise. Our divisional involvement, I like to bring our residents and our medical students. This is Sally Boyd with her child here smiling at me, wants to be a vascular surgeon. So this is important because I think this brings students in to understand the daily activities of vascular surgeons. So I think part of it, and Dr. Conte kind of mentioned this, is that sometimes I think students, there's a big threshold for them to kind of come talk to us and engage us. If they know that we're walkie-talkie people that have lives and that we have the same stress as they do, they're more likely to engage with us. And I think this is a pretty crucial thing. We also encourage our medical students to attend virtual meetings when our residents, and this is Sally here presenting at the VEST meeting this past winter time. And then we also, this is part of a new thing that we've done a lot of, which is looking at virtual advisors externally. So we have actually paired with other vascular surgeons, not only in our state, but also through the region. So this is an example here of one of our general surgery residents going through a presentation she did for the Southern Association, where she actually presented to Megan Tracy at UVA, and we got some really good feedback from her. I think this is a pretty great way of connecting people virtually in terms of virtual mentoring, and it's been pretty successful within our work. As meetings open up, the sun will come out. This is James Dittman, one of our 4th-year medical students, Diana Toya to the left, Sally Boyd, and then Wayne C. Wayne is applying for fellowships this year. In person is crucial. Be aware of the restrictions, as we all know, but be strategic in your submissions, I think, is part of this. When we do get back in, this is an example of what I used to do when I was physically on ground. This is 1, 2, 3, 4 students. You can see Dr. Jason Lee in the background here. So this is the VAM. I used to do these walk rounds in the exhibit hall. I think this was crucial for students to understand. This is Catherine Morrow, who's at MGH now. And so this was crucial to have students interface within the exhibit hall to understand exactly why things are the way they are, what are the restrictions of the devices that we use. And I think it really helps them to understand the technology and the interface and a lot of the excitement for us in vascular surgery between the technology and kind of how we handle our patients. And I think close mentorship meetings, especially at the poster sessions, are crucial. So this is Kayla Rutherford. I lost her to interventional radiology. So that's a good, bad thing. She's in a career that she's happy with, but I didn't get her into vascular surgery. And then Gianna Costa, who went on to general surgery at Case Western. Engage after hours and make connections. I think this is pretty crucial to have students. I try to invite them to when we do have engagements after hours, not only in the National Vascular Meeting, but also locally. And then I also encourage students to attend in groups. So this is Catherine Yu, who's actually one of our categorical residents, who attended a meeting or SVS meeting with a friend of hers up in Boston. And then I think you direct students to senior mentors. This is actually an email that I sent to David Rigberg at UCLA, trying to connect him with one of our medical students who actually attended VAM this year because I was not able to make it. But you need to balance engagement with those who cannot attend in person. And this is from the PNEC meeting here. This is Diana Toya, who we got paired with a Stanford group. Next year, we will bring our own team if Niten will let us bring a full team from VCU. So 10 tips. Okay, 1, I think you identify your base, your students, identify them early. Look for self-starters, look for motivated learners and leaders. This is James at the recent VAM with Danny Shu from Iowa again. Check out the SVS online website for resources. The ideal VSIG calendar around the VAM is how we kind of usually set up our year. We look at regional organizations as well. And we're always looking at what other VSIGs are doing. And I think the Western, you guys have some really good resources out there. And the Midwestern actually is just getting ready to have a good medical student program as well. Look at social media, document the team, set up a web page. We initially had something called Vascular Coast to Coast, which it was a lot of work to do, and Niten actually sat down for an interview with us and did a podcast, and we did a couple podcasts. You have to really have someone who's dedicated to that. So I've kind of backed off of that, but we do have an active Facebook page. But digital footprints for the medical school and connecting them are pretty crucial. Active mentorship at the national meetings, day-to-day schedule. So for example, for VAM before we were not able to attend, I had set up a day-to-day schedule with potential people that I wanted our students to meet with. And warm handoffs to students in person or virtual are crucial. And then you need to provide context of who is potentially someone you would want to meet with as a student. So I think a lot of it is you're kind of the tour guide to vascular surgery, and you kind of help students kind of navigate some of these waters. In terms of research, define your projects, mentor your students, expect to meet them more than halfway. And then you want to, again, expose them to local and national meetings. And this is Julie Fleschlag. I was meeting with 2 of our previous VSIG members here from the annual meeting when it was up in DC. Shadowing is important, but like I tell students, what happens at the end when the sun goes down, the shadow's gone, you've got nothing left. So I always tell them, think about OR jump seat, bring them into the operating room, let them see what we do in the midst of an operation. But educational conferences is a great way to engage them, and also divisional conferences as well. And then they define the engagement. I think it's pretty crucial. They kind of know what they want out of the experience. It is their schedule and it's their original ideas. Expect failures and miscommunications with these learners. I think it's really crucial. You have to meet them sometimes more than halfway. And then engagement continuum. Always make sure they want sometimes limited engagement, but sometimes they want full engagement with you. So you have to kind of play that on a case-by-case basis. And team projects sometimes, especially if you have students that aren't engaged, I think is a good way to keep them involved. But students want teams, and this is an example of all of our research residents from this past year, this past summer that did research with us. And we actually had a team set up where we had our research residents, but also our general surgery resident who helped out, and then James Dittman as well, who was the previous president of our VSIG. So it's crucial to set these teams up. And finally, set up gets a grassroots efforts within VSIG, train and encourage your residents to be mentors, and then research dynamics, I think, are pretty important. So what is the new normal or new abnormal, or where are we? I think we're going to see more virtual engagements. I think that's a good way of getting our students in. Hands-off, hands-on workshops, for example, in this virtual escape room, I think will be pretty crucial. Hire and select good mentors for your ranks, I think are important. Develop mentoring and exposure materials for vascular surgery. Increase virtual mentoring of students and trainees locally. Maintain national mentors for trainee networking. Continue to attend and promote learners at the local meetings, and selectively attend national meetings and connect virtually with the students who focus goals. But VSIG involvement is marker of early and continued association with our specialty. This is crucial. And remember that when we move forward, the best in-person and virtual activities to recruit, mentor, and develop our current future trainees are going to be crucial to what we do. This is the real reason why I do what I do. These are the people that I've influenced. I've had a very small part in their training. So Grayson Pitcher, who was the first person to come to me and say, hey, we need to start this. And it's an error in education if he happened to be in a vascular rotation at the VA and now is a vascular surgeon. So he recounted that. I went to his wedding. He recounted that story to everyone at his wedding, which I actually was pretty touched by. So he's the reason that this talk is happening. He's the reason that I run a VSIG and I'm involved with our students. So I owe a lot to him. And sometimes your trainees and your learners will help you really understand what you really need in terms of your career. That's just my advice. But Jana Costa now in general surgery, Brandon Gaston, who finished in 20, is now at MGH, and then Danny Shu just passed this past year in Iowa. And then this is the next generation of our current students, and James Dittman, who I had mentioned a couple times, Mihan Bentham, Sony Lili, Ashwin Gurnayam, and Yuchi Mom. So you will see their names. You're going to see their posters. So we have lots of projects out there, but this is the real reason. I thank you for your time. I thank you for your efforts. I think you guys are right on the direction that you need to be in the Western Vascular and trying to engage these learners. Please feel free to email me. I'm happy to answer any questions now. If anything occurs to you later on, please follow us at VA Vasc or at VCU Vasc Squad. And that's it. So if I can stop sharing. There.
Well, thank you, Michael. That was fantastic as always. One of the things that you brought up before to me and we've discussed is that it seems like, probably not pre-COVID, it seemed like you could get the medical students when they're a first year and they're hungry. I mean, literally hungry for pizza and literally hungry to experience something clinically. And you get them in for the second year, and then you lose them during the clerkship time. But you have a philosophy, right, and a method to keep those students engaged throughout. And as you said, they may not go into vascular, but it opens up options for them. Can you tell us a little bit about that?
Yeah, I think you set the expectation. So we're actually doing our in-person. We're resuming in-person kind of launch meeting this Friday. So I always start the lecture with, my job is I don't want you to be a vascular surgeon. I don't want you to come into my field, and I don't want you to take my job. So when I say that to these learners, they're like, why is he saying this? Because they're so used to being courted and brought in and sat down and please, let's walk through together in the valley of vascular surgery. So I tell them that, and they say, why is this guy saying that? And then I talk about why I like vascular surgery and why I think our field is fantastic and why I think that we are moving in the right direction. Yes, we have our problems, but when you say that and you tell them that and you have enthusiasm for it and you're engaged and you allow them to engage you, then the ones they self-select, and those are the ones that end up interfacing with you.
Mike, I think that's actually a good point. And before we started the webinar, Niten and I were both talking about how we come from universities that have a big primary care focus. And when I sit down with these students, we talk about how I am the primary care doctor of, of surgery. And I like that. And I think it really engages them because I don't care what they do. I just want them to do something they love. And because they're so focused on what they've been taught, which is primary care or this kind of stuff or rural health, and then they see the things we're doing and they're like, oh, maybe I can do that. So I think that's a really unique philosophy.
It is, and it's interesting. So when we survey our students from VCU and they come rotate with us on vascular, what they consistently love is what we as vascular surgeons sometimes don't like the most, which is clinic. They love seeing manifestations of everything that they've learned about hypertension, diabetes. They love that environment. And when they see how we deal with that, and we deal with all the medical parts of the hospital, and we show them that, they do get turned on by that. And I think they really have a deep appreciation for what we do as specialists. So I think that's the other component of this, is that we won't always get stakeholders to train within our ranks, but we need to increase our visibility and our brand. And we need to do that on a day-to-day basis, especially with those that are going into fields that are eventually going to refer to us.
There was a couple of questions, and you mentioned this several times about how to get it started during COVID. And this question is for both you and for Mike Conte, because, Mike Conte said, I started it during COVID. So that's an interesting concept as well. So maybe you can talk about how you do it during a time. And I know you mentioned like the couch thing and all of that. How do those of us that don't have one just say, okay, tomorrow we're going to start, here's the first thing I should do?
So, I'll let Dr. Conte go first. Dr. Conte, how to go? Oh,
yeah, no, I was just going to say that I mentioned that we had this event, which was it wasn't an official VSIG event, but it was an in-person opportunity where we had a big turnout for a training session, and sort of the whole thing sort of spawned. So we had a bunch of people who were really excited, and then we kind of formally started the VSIG group right after that. And that was the last time we actually saw everybody in person. So it was a little bit of on the cusp of the pandemic. And, honestly, we've had our integrated residents, and one of our current integrated residents, who was a medical student then, has really been an incredible driver of maintaining momentum. I mean, that's really where a lot of the positive energy comes from, especially during this time when people are not physically around.
mm-hmm.
So we have had to rely a lot on senior medical students and integrated residents during this to keep the group kind of together.
Yeah, and so I think, and the way we've done it, Misty, to answer your question from the VCU angle, is we've always paired with our medical school to say, okay, how do the interest groups, what is the interest fair? It used to be a fair where we would have a table, and now that's become virtual. And so we always get into that, the nitty gritty of that. And it's very important because VCU's got a big primary care base push as well. So unless you get there and say, how are you engaging students for everything, the interest group for OBGYN, you need to be at that table, either virtually or in person. And then also, if you do it in person, to just to promote it the best you can. And grassroots VSIG, if you say you're providing pizza and you know that they have a break between 12 and 1 o'clock, between the morning and the afternoon, they can be, want to be a pathologist, but for that hour, they're going to want to potentially think about vascular surgery, and that might be someone that you can convert. So that's kind of been our angle. But I think Dr. Conte hit on a good point, which is you need somebody to bridge between us as vascular surgeons and trainees and medical students. And when you have someone that's an internal person that you've taken into your residency, I think that's a crucial piece in creating. And so my next goal is, so when I have these medical students who leave and go into residency, still have them in some way in a mentorship capacity back at VCU to help me still connect with other students.
I think that's great.
I'm just going to make one other point that I think, Mike, amply touched on a lot of activities, but kind of once we identify people as being in the orbit, we copy them on everything, so our weekly walk rounds, if they're interested and available, they can show up. Our vascular conferences, our teaching conferences. So, and, we don't keep track or sort of measure or monitor whether they do or they don't. But I think that, we open it up, we sort of put them in the same universe as our trainees for communicating those opportunities.
That's great. Dr. O'Banion, I think there's some questions that you've been monitoring from the group.
I think Dr. Conte actually just answered the one that I think I was getting ready to ask, because I was actually interested. Do you invite your medical students to participate in the weekly vascular conferences and get them involved? So I think it's great that they have the opportunity to do that. I don't know, Dr. Amendola, do you guys do the same thing?
We do. And a lot of times what's interesting is we try to involve, we have a research. So in the summertime, we have a weekly research meeting, and then also during the year, if we have those students present at a national conference, we'll actually have them present at one of the divisional meetings. So then we have attendings that are able to give them feedback, but they're also able to listen into what our typical data, our week to week kind of vascular divisional meeting is. So again, making kind of the visceral kind of experience for students to say, okay, this is what Amendola's week is like. He actually messed up this case. He actually said he messed up this case, and how could he have done it better? So I think that visibility and that kind of nuts and bolts, and that's, I think, what Dr. Conte was kind of hitting on, getting people involved, especially the students from the very beginning with the nuts and bolts, is pretty crucial. But again, remember, be ready to fail, be ready to lose students. There's nothing like going to graduation and sitting there and they say, this person's going to internal medicine, this person's going to cardiology. And these are people that you've written papers with and had posters with. But again, what we're trying to do, and when I say we, kind of the VCU, my little mantra has always been to help students discern. So when they sit in front of you guys for interviews, you have somebody who's really thought about this specialty and really wants to do it. And that's the thing, is we only have a certain number of shots in the chamber. We've got to train the people the best we can, and we've really got to keep them within this educational model. So it's very crucial. The discernment is very, very crucial.
We're on the West Coast. We're not gun people over here.
Oh, sorry. Well, we have a certain number of kale gardens, and we've got people with kale. As Kadar says, everybody eats kale out there. So I love kale. But anyway,
we're up in the Northwest.
I'm not pro-gun. Don't everybody, nobody get excited. It's the South. Sorry.
One of the things that I think you said too, and you touched upon, is getting students involved. And one of the things we've done in the past is the same, and we've talked about this before, but we have a week-long cadaver course where we have residents of various levels doing different types of operations. And what we do for that is we have the medical students then trained to be the scrub tech and handling instruments and understanding what the instruments are, because then they get to see the procedure as it's being done on a cadaver. So they get to do parts of it, and they get to learn the instruments too. So I think just getting them involved, and one of the things I've seen, and is be interested to hear other perspectives on it too, is that, anything that involves suturing and technical ability, everyone's all in on that, because I think they believe that they're supposed to show up on the day one of their surgical rotation and be Dr. DeBakey. And, it's interesting to watch, them really get frustrated with not being able to tie a knot. And, just us telling them, look, it takes time to learn this stuff. And I don't know what your experience with that is, but I think those are always big hitters for medical students.
I think you're absolutely right. So commonly we will have students come to the operating room, and it's, so here's the iPhone, right? There's a lot of things that go on to make this thing work, and we don't know anything about that. So I tell the students all the time when they come to the operating room, I tell them, tuition, come here, tuition, feel this artery, tuition, feel, I mean, and they're like, what do you mean tuition? I'm like, you are physically paying to be here. You need to experience this. So you really need to be explicit with this learner class to tell them that. The other thing is when they do things and and there's a lot of self-doubt of, oh my God, I did this wrong. I tell them, I say, it's okay. You're not supposed to know that. So I think you give them permission to be the learner And I think that's pretty crucial. And I do that with our residents all the time. And sometimes if the resident doesn't show up for the case, I let them use a 10 blade and cut on the line. And they are like, oh my God, I never knew I would do this. And this is so empowering, but I don't know anything about this. How are you letting me do this? And I say, I don't know. Should I be letting you do this? So, but you create that environment where they're like, why is this guy interfacing with me? Because they're so used to, don't talk to me because I'm the surgeon. But when you bring it down, you say, you're paying to be here. Here's the tuition. You touch this, do this, and you really make it explicit in the environment. I think it's pretty crucial. And you turn a lot of students on to vascular, or even think about it, or start to think about it as a career path.
Hey, Niten, I think we have one other question, which I think is actually kind of interesting. So has anyone had any success using a single session of the General Surgery Interest Group as the springboard for VSIG? And I think that kind of touches on a couple of the other questions that were in the chat board along similar lines, especially with everything being virtual, especially here in California with COVID. How do you get started? How do you get that first 20? How do you capture them to even get them? How do you snag them from the get-go?
So I think you need to have what we've done in the past is we've had panels, and people need to understand that there's a variety of ways of training. This is all, it's kind of mysterious to people who are actually applying. It's very mysterious to medical students. So you literally have to lay it out with them. And I think having a panel is a natural way. The way we've done in the past is we've had panelists, and then we've actually had students submit questions or come up with questions. And I've worked with leadership, and they said, okay. And then they just ask us questions to direct the conversation. So it's a natural conversation. It's like being at a cocktail party. After a couple minutes and a couple drinks, you figure out what this person does, what that person does. It's the same thing within a panel, and students get a lot out of that, more so than me. They saying, why are you a vascular surgeon? Tell me how you became a vascular surgeon. You show the contrast between the specialties. I think that's the crucial piece, because students will learn pretty quickly. I'm migrating more into this versus this.
Michael, Leigh Ann, to add to that, one of the things we did is for the in-person high volume events, which is always a suturing lab, we combined with the orthopedic interest group and the surgery interest group on those, because it just gives you more proctors, because those events are really heavily attended, and it's nice to have a bunch of different people being able to help them with that.
Yeah, and I think it is, because that's the coin of the realm. I learned to suture from a surgeon. I mean, that's kind of in their mind, that's a kind of a jackpot kind of educational, payoff. So if it's an orthopedic surgeon, if it's a vascular surgeon, if it's a general surgeon, putting all that in the group, I think it's pretty, because then what you see is you see conversations, and they engage you and say, what is it like what you do? What is, and you see nuances of that mentorship and leadership in different environments where you have, say, for example, large medical student groups like Mari Shames's meeting in Tampa, where they will ask me questions. What's it like being an academic vascular surgeon in the VA versus in an academic affiliate or in private practice? So I think you see a different level of questions, but being in the physical time with them and doing something, they naturally engage you as well.
That's great. If anybody has any other questions, they can type them in the chat and we can get to them. I think we pretty much touched on everything that everybody's typed in so far.
No, and I think this is really great, because I think with the new learning environment, we're all trying to figure a lot of things out. It's funny you say tuition. I tell them the same thing when they come in and they say, can I scrub in? I say, do you know how much you paid to be here today? You can definitely scrub in. You scrub into every case. And if somebody tells you can't scrub in, you need to tell them, do you know how much I paid to be here today?
Right. Well, and that's the thing, is that a lot of times if I'm assisting my other partner, I will step back and say, you can step right there. You're actually paying to be here. They're paying me money. I'm just here to help. I'm from the government. I'm here to help. Right. It's 7 most scariest words per ring. And I'm from the government. I'm here to help. So you do that. You create the environment for them to really be like, because they're used to this kind of edgy environment where they're not allowed to touch anything. It's very bizarre. They've got nurses barking on them. And so it's a real, so if you just cut the kind of the tension, they really like and I actually, one of the best notes, and I have it up on my wall in my office, is actually from a psychiatrist. And she said, you're the only surgeon I ever met who did not make fun of me going into psychiatry. I told her, I said, there's a lot of psychiatric pathology and surgery. If you just walk around long enough, you'll find it. And she said, you're the only person who just liked hanging out and talking about psychiatry. So we were talking about psychiatric diagnoses that I commonly see in vascular surgery. Again, engage them. So a lot of times I figure out what they want to go into, and I tailor, and I do that a lot with our general surgery residents. They want to do pediatric surgery, what have you. I try to tailor the way that I teach to that and make it relevant to them. And they really seem to really like that, because it's a check mark in their brain and say, I really like this because this is it's checking off something in my experience.
Well, thank you for being here. I really appreciate it. I think we've answered all the questions. We've joked, we've got to see each other. We've had a good time. And hopefully people have gotten a lot of tips about how to do this, how to get it started. And they're excited to take the next step, which we will be supporting with the Western Vascular Society. We'll also have more information on our website. If you are a student or have students, the deadline for the application for the stipend is on September 1st. So get your application in, and we'll be going through those at the end of the week. So thank you. Thank you, everybody.
Thanks,
Perfect.
Misty. Thanks, Niten. Thanks, Mike, Leigh Ann.
Thank you.
Great job.
Thank you.
Thanks, guys.
Take care, everybody.
All right. Good night. Thank you very much.
Good night.